Dr. HangJoo is an associate professor in the Department of Trauma Surgery. He is the director of the Regional Trauma Center in North Gyeonggi Province and the chief of the Department of Trauma Surgery. And is also the director of the Scientific Committee for the Korean Society of Acute Surgery and the director of the Training Committee for the Korean Society of Traumatology, as well as the director of Scientific Committee for the Korean Surgical Ultrasonic Society. And he will be reacting to the first talk by Professor Buffett on penetrating war injuries and guns and bombs. Prof. HangJoo first.
At first, thank you for excellent lecture, Professor Ken Buffett. And in South Korea, because of farm restriction in Korea, I rarely experience blast and gunshot injury. So I'm so sad. I want many gunshot and blast cases. Fortunately, I participate in Operation Iraqi Freedom as MNCI in 2005. And our trauma center is located in the very north of South Korea. And in the north, dangerous men lives. So there are many soldiers in this area. So fortunately, our area is relatively dangerous compared to our other region in Korea. About the foreign body removal, Professor Buffett said there is generally no need to remove it and comment about the indication of removal. And I think the additional indication include infection, hemorrhage, and more than 1.5 centimeter size, and for psychological comfort, and about the timing of removal. In cases of damage control surgery, don't remove it in the first operation. And this is a shotgun injury cases, and this is a bleed. Bleed went straight to the brain and abdomen. And in the first operation, I did bleeding control in the mandatory and repair the perforated valve. And I searched in the second operation. I tried hard to find the bleed with sonography. But because of the potential iatrogenic injury, I gave up searching the bleed, but I really wanted to find them. And about antibiotics, systemic antibiotics and broad spectrum covering aerobic and anaerobic is important. And Professor Buffett recommended augmentin and clavulin and capazolin. And I think altapenem and moxifloxacin are also possible. And in the operation for bleeding trauma patient, every 10 units of RBC transfusion or 2 hours into the operation, repeat 1 more dose is recommended. And this is an anti-tank mine explosion case. The patient comes to our hospital by helicopter, and he had already intubated. Both legs were injured and tourniquet were applied, and burn and chest injuries with shrapnel hole and facial injury also. And 2 tourniquets can be applied if 1 is not enough, I think. And initial BP was very low. And I saw a penetrating injury on his chest, on his anterior chest, and immediately sort of pericardial tamponade. So I did cardiac sonography, which turned out to be negative. And instead, I had tangent pneumothorax. I conducted the tube thoracostomy. So textbook said prophylactic chest tube are recommended prior to air transport. And looking back, I think it would be better if the patient had already had a chest tube before coming to the trauma center. And I did only consultation to IN ENT as Bopard emphasized. And rest cases, K1 rifle, brachial artery injury cases. I repaired the artery and nerve. Brachial nerve seems okay in the operation, but months later, the patient developed brachial nerve palsy. So I think this may be due to the shock wave caused by bleed, as Bopard said. So it's important to be mindful of that, I think. And my last slide, I have a question. Professor Bopard said about the pellet embolus by shotgun. Can you share your experience? Thank you for your attention.
Dr. Ashok Kannan from Malaysia. Dr. Ashok Kannan is a general surgeon and a trauma surgeon at the Hospital Sultanah Nora Ismail, Batu Pahat, Johor, Malaysia. He will be reacting to the second talk on the management of the polytrauma patient in extremis, mass casualty incidents preparedness, which was delivered by Professor Edward Tan. Dr. Kannan, please.
Hi, a very good evening from Malaysia. Thank you for the kind introduction, Mr. Moderator. And I would also like to thank the organizing committee for the in-kind invitation. First and foremost, it's a pleasure to be part of the esteemed team of Reactors. It was indeed a great presentation from Dr. Edward Tan in terms of mass casualty incident preparation and management of patients in extremist condition. First and foremost, because I work in Malaysia, we don't see much violent-related incidents. However, I was privileged enough to be part of the MSF project in Mocha, Yemen, somewhere last October. So that project is basically manned by 3 general surgeons and 3 anesthetists. And we had about 6 ER beds. We also had 6 ICU beds with about 30 beds in the normal ward. It was all in a container kind of environment. And we were serving basically war-wounded patients. As we all know, Yemen is undergoing a civil war for many, many years. And the front line is about 6 hours away from where we were based. So these patients would basically get first aid treatment in 2 hospitals nearby to the front line before being transferred to our center. So in this center, we also provide surgical services to other related trauma cases and also emergency obstetric cases as well in this center. So, my experience in managing mass casualty incidents, we had a couple of them, and the biggest, as we said, we only had 6 beds. The biggest, we had 47 patients, basically red and yellow cases coming into our doors on a Friday morning. So that was relatively overwhelming for the amount of support, amount of medical personnel that we had on the ground. But having said that, I would like to touch on 5 critical points that Dr. Edward Tan has already spoken in great lengths. First and foremost, I believe in having a proper triaging system. Many of these patients come in with lots of multiple bullets in the chest, in the abdomen. Many of these have vascular injuries, basically at the posterior aspect, and is easily missed if a thorough examination is not done. So I would really emphasize on a proper ATLS principle guided management strategies in order to identify these life-threatening injuries and treat them in a very emergent fashion. Second of all, I would like to touch on having a good interpersonal relationship with all the team players in managing these trauma cases. I would like to share that I had an amazing anesthetist, Sophie, who worked in a trauma center back in Belgium. So that made it very easy. And of course, the nurses are relatively quite familiar in a trauma setting because they have been dealing with this kind of cases day in, day out. So it was relatively important to understand the principles of trauma care, especially when you have a mass casualty incident. Third of all, I would also would like to touch a little bit on the capabilities of that mission. We did not have much capabilities, like we did not have sets for neurotrauma. So all these cases has to be transferred to nearby centers. And I also like to touch a little bit on the importance of having damage control strategies instituted in these patients from the word go. The reason is because most of these patients has to travel at least a good 2 to 4 hours before reaching to our center. Majority of these patients had tourniquets. Some of them had bandages, compression dressings on the chest wall. Some of them had chest tubes. So we had to do something very emergent. We had to get them, to bail them out and then correct the physiology. I think that has to be given lots of importance. And training of staff prior to crises. You can't train them at that point of time. So everybody has to know their roles, responsibility, what they're going to do, where they're going to be stationed when a mass casualty incident is called. And I think Dr. Edward Tan has spoken in great lengths in that. And last but not least, I think auditing a system, right? The only way to improve the system is by auditing, looking at the timeline from the time a patient arrives at our doorsteps. How long do we take these patients to the operating room, and what are the ways to shorten this timeline in order to get a better patient's benefit? With that, thank you very much. I would like to say to Dr. Edward Tan for his very good presentation, and to the rest of the speakers that have given their talks. Thank you very much.
Dr. Nat Krairojananan, Colonel. He's a Colonel in Medical Department of Royal Thai Army, and is a consultant surgeon at the Department of Trauma and Emergency Medicine at the Farm Kilo Center. And he has got multiple deployment in military deployment, including the East Timor in 2000. Over to you, Dr. Nat.
Good evening, everyone. I'm Nat from Thailand. I'm the reactor for Dr. Avi's presentation. Dr. Avi gave us a great presentation about the medical education in IDF. I was in the Israel before. The Israeli has a sophisticated training center, so I believe that they can train their physician, and they can the physician can handle every casualties. I would like to compare about the Israeli doctrine and the Thai doctrine. Thailand is such a small country, so we set up our force as a conventional warfare. We do not deploy abroad, but we have some counterinsurgency operation in southern border of Thailand. So as a conventional warfare, we set up the smallest medical unit in the battlefield. It is a battle aid station, or BAS. The battalion aid station is belong to infantry or cavalry battalion. There is only one doctor and about 20 to 25 medics. So in Thailand, we have data records about the mechanism of injury from the battlefield. Most of them are the non-combat injuries, such as the traffic accident. As we know, that Thailand is the most dangerous country. We have a highest people dead from road traffic accident in 2019. But from the real injury from the battlefield is from the blast injury, especially from the IEDs. So the wound of death is a secondary hemorrhage from the extremity. So we have to design or tailor-made our medical education for our medical personnel who goes to deployment. The medic men, they are usually graduated from the 9th grade high school, and then they go to the Army Medical Field Service School and take 1 year to get their EMTB graduation. So they need some additional training such as BLS and technical combat casualty care. For doctors, we have to teach them about the ATLS, the technical combat casualty care. And nowadays, Thailand have a problem about the evacuation. we do not have enough aircraft to evacuate the patients back to the MTF. So we are developing the prolonged field care or prolonged casualty care. For the surgeon who deploys to the field have to study about the access costs from the American College of Surgeons. And if we have a trauma surgeon, we have to send them to study about the STC. So what is the challenge of the medical education for the military doctors during the COVID-19 pandemic? Nowadays, we have a problem about the COVID-19, so we have to be apart. We have to take a physical distancing. So most of the students, they study online. They need a lot of discipline. They have to pay most of their attention and responsibility to study by themselves. The advantage is they can learn anytime or anywhere, but they have to attention by themselves. The solution for the study with this method is we have to develop some application or use the interactive online, that we have some quiz or some question during the lessons, so they can do, so they have to focus more than that. Secondly, nowadays we integrate the IRAD or GRAD, the individual or group readiness assessment test or group or readiness assurance test to make them focus to the lesson before they join the class. Secondly, due to COVID-19, the decreased number of trauma cases, so they have no enough case and variety of case for practicing before they deploy. The solution is to set up the simulation or scenario-based learning. Lastly, about the special issue that Dr. Binoff tell us is about the use of TXA. Nowadays, the TXA is safe enough to use. About 5 years ago, we are afraid about the use of TXA because TXA may cause the orthostatic hypotension, and we have to drip it slowly. The new technical combat casualty care assurance us to give the 2 grams of TXA slowly intravenous push. And then about the data collection, it is important. If you see the casualty card DD 1380, you will see the box that they will ask you to fill the form, which kind of tourniquet that you use. I used to ask my instructor once when I was in the US. He said, "Oh, that is for the data collection and the research in the future. There are many commercial tourniquet, so you can evaluate every tourniquet in the field." Lastly, all combatants must learn the combat lifesaver so they can help themselves. Thank you very much for your attention. Sawasdee krap.
Dr. Tamara Worlton will be reacting to Professor Mansoor Khan's talk. Dr. Tamara Worlton is Associate Professor of Surgery at Uniformed Services University, and she's a Director of the Division of Global Surgery and the Director of Surgical Operations at the Center for Global Health Engagement. She had multiple field deployment as a field surgeon and as a ship surgeon to Afghanistan, Djibouti, and in US Navy ship Mercy and Comfort, including recent deployment to during the COVID pandemic. And currently she is in Sri Lanka as a Fulbright scholar studying Sri Lankan trauma system. Over to you, Dr. Worlton.
Thank you. And the most important thing, right, is now that I am a member of the Ambrose Paré International Military Surgical Forum, and I am recruiting as we're speaking for other people to join. So thank you so much to the Asian Collaboration for Trauma, for all my friends It's great to see you, at least virtually, and hopefully we can meet again in the future in person. And I'm excited to react to this excellent talk by Professor Khan. He definitely highlighted the numerous contributions that the lessons learned from the battlefield have been translated into the greater management of not only just traumatically injured patients, but medical issues in general. I do want to take this opportunity to highlight that these innovations did not arise spontaneously. The meticulous recording of subjective and objective data is critical to understanding the patterns of injury, and more importantly, the subsequent scientific analysis and publication of these findings is key to the preservation and propagation of this knowledge. Indeed, he mentioned that many of these key surgical concepts needed to be rediscovered after times of relative peace. He mentioned tourniquets, which had been a common thing used in the 70s and 80s in the United States, but had fallen out of favor and had to be rediscovered during the Afghanistan and Iraq conflicts. The loss of these hard-won lessons occurs in both military and civilian surgical societies and has been referred to as the Walker's dip. This phenomenon underscores the importance of two things. First, the collaboration of military surgeons and civilian surgeons to maintain critical trauma skills for the military surgeons during times of peace and for civilian surgeons during times of war. And Dr. Elster referred to this because we have a very long document, the Zero Preventable Deaths, that outlines how civilian and military trauma systems need to integrate in the United States. Secondly, it's incredibly important in the advancement of trauma care to invest time and resources to this meticulous data recording. We've heard this in multiple talks today and from multiple reactors. The decrease in deaths, in traumatic deaths in the Afghanistan theater is not only due to our continued experience in the theater, but also was helped along by the Joint Theater Trauma Registry, the JTTR. This was modeled after the U.S. National Trauma Data Bank, which functions and has been replaced by the Trauma Quality Initiative Improvement Project. Sets standards of care, measures outcomes, promotes best practices, and ensures adherence to continuous process improvement. The JTTR, after it was established, then helped the civilian system with its robust severe polytrauma data, including blast injuries, in all the ways that Professor Khan discussed. I truly hope that these lessons do not get lost in the passage of time, and that we as surgeon scientists continue this acute attention to the prevention and treatment of traumatic injury. We have the opportunity to build upon these fruitful collaborations with the Ambrose Paré International Military Surgical Forum, and I hope that this initial and historic collaboration will continue in the future. There's a wealth of wartime surgical experience from every corner of the world that's held by the members of the society. And as we so acutely feel today, the absence of Dr. Norman Rich, who has done so much for the advancement of trauma care and trauma vascular care, that we need to have these opportunities before we lose these very valuable members and their knowledge and their friendship forever. So I did have a question, because this was such a fun topic. I want to push it a little bit further, and hopefully we'll have time for this, and maybe the diehard people who are still hanging on after 2.5 hours of this conference will stay on for this question. So we've talked about trauma care and the innovations, and even some of the forward leaning, looking at how the next generation of military trauma care is going to be. Now, I have to say that in the US, there's a lot of interest because we have established the Space Force. We do not have a military Space Force medical contingent yet, but the military medical community has been working on this. And actually, in the most recent SAGES conference in Denver, there was a whole panel on surgery and surgery in space, because when you look at zero gravity, hemorrhage doesn't just stop, and being able to maintain pressure and encourage clotting has its own difficulties. We're also looking at developing remote surgery technology with the Da Vinci platform, and there's been several tests of operating the Da Vinci platform from a remote location. And so just with these kind of examples, I would love to hear what we think the next revolutionary step in medical technology development for military surgery is. Thank you all. Over.